I'm Dr. Ken Ellenbogen, and we're here in Boston at the AFib Symposium. It's really a pleasure to be here with Professor John Cam, who is the British Heart Foundation Professor of Clinical Cardiology at St. George's Hospital, which is part of the University of London. And Dr. Cam and I have been having a conversation on antiarrhythmic drugs, and I'm going to ask Dr. Cam, or Dr. Cam's going to tell us about some of the new antiarrhythmic drugs that are in development and we might be seeing in the next 2 to 5 years, both in the United States and in Europe.
Well, I think we're just getting used to a brand new antiarrhythmic drug called dronedarone. But after that, there comes another new antiarrhythmic agent, which is called coolant, or coolant as I call it. This drug is a multi-channel blocker, but to some extent it's specific to the atrial myocardium. It inhibits a current which is called IKUR, the ultra-rapid potassium inward current. And this current is specific to atrial tissue, and therefore this drug will prolong refractoriness in atrial tissue more than in ventricular tissue. So we don't expect a lot of QT prolongation and torsade de pointe, whereas the advantages of prolonging refractoriness in the atrium will be preserved with this drug. The drug is also a sodium channel blocker, and a lot of its efficacy may come from that particular action. Vernaculant's now been tried in 5 studies, which have all been called ACT, arrhythmia conversion trials, because it is given currently as an intravenous preparation with the idea of terminating atrial fibrillation. Most of these studies have been in patients with recurrent atrial fibrillation in no specific circumstance, but they come with a new onset arrhythmia and the physician decides to try and terminate it and achieve sinus rhythm. With vernaculant, the outcome is that if you find really early onset atrial fibrillation, you can have as much as a 70% response. But if you take patients who've had atrial fibrillation for up to 7 days, then the response rate is 50% converting to sinus rhythm, which is a very good response rate. The drug is given as an intravenous infusion, 10 minutes, and then wait for 15 minutes, and then a second infusion for a further 10 minutes. The average time to conversion of the arrhythmia is just a little after the end of the second infusion, so it's pretty quick. This drug does have a minor effect on the QT interval and on the QRS duration, and you can see that effect as you infuse the drug. If you follow that effect, it's completely evaporated by about 1.5 to 2 hours after the infusion, and therefore any lingering concerns about the effect of the antiarrhythmic drug can be dispensed with at about 2 hours' time, and the patient would probably be able to go home at that particular period. It's been a very successful development program, but there have been a few complications with the drug, particularly in patients with heart failure, where patients have become hypotensive. And so the development program is continuing for the time being. And a new trial called ACT-5 is now underway, and this study is going to emphasize the possibility of any adverse effects with the drug, in the sense that one of the primary outcomes is a safety outcome, looking for hypotension and looking for ventricular arrhythmias. On the other hand, again, it's going to extend the efficacy information with this drug. Altogether, it looks as though it's a very good drug.
Are there a host of other drugs, or different types of channel blockers, drugs working on connexins that you foresee in the future?
There are very many new molecules. We don't know how far any of them will get, and none of them are anywhere near clinical use. A few are being more or less developed for clinical trials at the moment. There's one drug which is a pure IKUR blocker, which is called Zen 0101. It's still a number, but it's very promising. It affects only the atrial myocardium, absolutely no effect on the ventricular myocardium, and that's now in proof of concept studies in people. There are other drugs like ACH inhibitors. And this is an interesting idea because this current is constitutively activated during atrial fibrillation, and so it makes sense as a target for the treatment of atrial fibrillation. Again, that's a drug with just a number, NTC 801. It's still in very early studies, but I think it stands a chance of being a highly effective antiarrhythmic drug.
So a lot of new drugs, a lot of opportunities, I think, particularly I think in older patients in whom catheter ablation still has not been widely practiced. Thank you very much, Professor Kam.